Welcome to Vision for California, a web series of discussions on California healthcare reform, hosted by Senator Dr. Ed Hernandez, Chair of the Senate Health Committee. Today's guest is Patrick Johnston, the CEO of the California Association of Health Plans.
Welcome. As you know, with the Affordable Care Act and the implementation of it, and I've said this publicly everywhere I go, that I believe it's the absolute most important piece of healthcare legislation that has occurred in this country since the mid-'60s. And of course, with the most recent ruling by the Supreme Court, California and this country is going to continue to move forward. So my question is, what are the plans doing to get ready and to implement the ACA?
Thanks for the invitation, Senator. It's a pleasure to be here. The Affordable Care Act is the highest priority for health plans in California as well. We're committed to its successful implementation. That means working with state officials and also with providers and consumer groups to make sure that adapting that law to California with our different geography, our large population, our areas that have a lot of resources and those that don't have too much can work, and also trying to constrain the costs that are driving up the price of insurance premiums, but also the cost to the state of California and the federal government.
What are some of the challenges in the implementation? 2014 is right around the corner. It's here. The exchange is going to be signing up individuals within the next 6 to 8 months. What are some of the initial concerns that you have with its implementation?
The exchange is intended to be a marketplace where people can easily go online or pick up the phone or go into an office and make a choice about health insurance coverage if they choose to as individuals or as small businesses, and then based on their income possibly get a subsidy, and sometimes a very important subsidy to make that insurance affordable. Well, if you overlay that intent, which is very good, with the map of California, you see areas of concentration where there are a lot of hospitals and doctors and specialists, but areas in rural California, but also in some of the more urbanized areas where there simply aren't enough providers.
Okay.
If the payment schedule is what Medi-Cal has had to be in recent years, it will be hard to generate enough providers for the amount of people who come.
And I couldn't agree with you more, and we've had the various professions come in and we've talked about that same issue, and that has to be one of your biggest challenges, and obviously one of mine, to address the workforce shortage. Let's switch gears a little bit and talk about the implementation of the ACA, but more importantly, some of the more popular segments of it, or applications of it. For example, allowing your children to be insured up to age 26, no pre-existing conditions, some of the free screenings for seniors, etc. A lot of those have become very popular since its inception, although the public doesn't really know about it. And I know that now that they're starting to find out about it, a lot of your plans are, even before the Supreme Court decision, were saying that they were going to start doing that. Let's talk a little bit about that. Why is that, and is that just because of public opinion? And tell me the thought process behind some of your plans.
Health plans are the invention, really, of the last 30 to 40 years of managing care rather than just paying a percentage of a doctor's bill. That fee-for-service system can generate a lot of activity, but not necessarily coordinated care. So health plans do want people to get preventive checkups and to have diagnostic tests that can be helpful to screen and find disease and treat early. So the new law makes it easier to do that by saying that there won't be the cost of many of these preventive measures. Right. So that's good. The one thing we always have to remember, though, is that they do have to be paid for. The machines, the technicians, the physicians who review tests, and all of that are a cost to the system. But taken as a overall strategy for California, they're very good, so that people like someone in their mid-50s who doesn't get a colonoscopy and then has expensive surgery but may die anyway of colon cancer, a relatively low-cost test and now a free test means that that person may live longer, have treatment, and it's a cost savings as well.
Good, good. Well, that obviously kind of leads into my next question, and you kind of opened with it as well with some of your opening remarks about increased cost of healthcare and how we reduce it. And of course, with the inflation of healthcare being 5 times that of the general, of the inflation, how do you see and how do we reduce healthcare costs? And in your opinion, what are some of the cost drivers to that?
Sure. That's a crucial feature of this whole debate, so that the aggregate cost of healthcare doesn't become so much of the nation's productivity output that we unbalance the economy as a result. So it's important to look that cost drivers are everywhere. That means that in some cases you have lack of competition among healthcare providers. That makes things more costly. Health plans need to be more efficient. The use of computers and electronic medical records ought to reduce the back office staff that doctors have to try and communicate with all the health plans to get the information so that they can bill. These are partially complications that health plans should work on. But another cost driver is really that if Medi-Cal underpays doctors and hospitals, they turn around and look to commercial health insurance, employer-sponsored, and individuals to pay for that coverage. So having a reasonable cost structure for Medi-Cal is good too. And of course, generic drugs where they're appropriate rather than those high-cost name-brand drugs. That's a trend that's been in place for a long time and ought to continue. So all of these are areas.
Well, let's follow up a little bit on some of your comments, and I couldn't agree with you more, especially with the cost shifting for Medi-Cal, the lower reimbursement rates that the state pays to its provider, more importantly, the network adequacy or inadequacy they have in those particular provider networks. But here's the problem is the state has a problem with generating revenue. I don't anticipate that coming soon that where we're going to have more revenue coming in for reimbursement rates. There is going to be a slight window in 2014 where the federal government will be between 100% of Medicare. That'll help offset it for a while. But we have to make sure we address, number one, the Medicaid population. It's going to be increasing. More importantly, the reimbursement rates for that have network adequacy so that we don't have that cost shifting. But what are obviously some of the other cost drivers, and how do the health plans address them? For example, like high diabetes rates, obesity. You look at end of life, for example. 30% of healthcare costs are in the last couple weeks of life. How are we going to address the overutilization of expensive treatments like CAT scans, etc.? How do we? I know it's a lot to ask you, but it seems like we need to start looking at those as well.
You've identified all areas that are important. End-of-life costs are high, but really the decisions ought to be the patient, the family, and the physician. Health plans are there to be supportive by making sure that hospice, for instance, and other palliative care can proceed even while curative measures go forward. But no one wants the health plans to make those kinds of decisions. We do think, though, that having a team approach, and you and legislators have pioneered the notion that for our frail and elderly who are Medi-Cal and Medicare eligible, that they will begin to have an integrated treatment plan that includes the social services and the in-home services that are necessary. All those can keep people out of nursing homes, which are far more expensive, but they can also improve quality of life. We also think that increasingly, and the Affordable Care Act aims us all in this direction, that health plans, hospitals, and doctors can work better together. Those are called, accountable care organizations. And some of them are in place now in California, and that means, for instance, less unnecessary readmissions. In the past, sometimes people would be released from a hospital, they'd go home, they wouldn't take the medicine, they wouldn't see a doctor as a follow-up. Maybe they didn't have help to get there. Now it's really the duty of the hospitals, the doctors, and the health plans to make sure that people aren't in the lurch and coming back in an ambulance in a couple weeks.
Well, very simply said, what we need to do, I hope you would agree, is we need to start treating individuals to be healthy as opposed to treating sick. We need to make sure that we have coordinated care. And unfortunately, I think providers have to start looking at seeing more patients more efficiently at a lower cost. One final question before we close. I'd like to kind of just talk to you about, medical loss ratio. Obviously, those are things that the plans through the ACA, there's 80% spent on healthcare, but there's still that discussion that, for-profit entities shouldn't be allowed in the healthcare system, and that we should move to a single payer system. Tell me a little bit about why you think health plans still play a critical role and how you would argue or you would counter that.
Well, the importance for any individual and family is the ability to see a doctor, to get medicines, to have access to a hospital, and all the important health care benefits that we have available in the United States. But somebody has to manage that because it doesn't manage itself. And so a Medicare system that was all fee for service may not have paid physicians and other providers enough at times, but they tended to pay every bill, and so you ended up with billions and billions of dollars of fraud, which the Obama administration is working hard to reduce. Health plans are really the intermediary. Their job is to make sure that there are the doctors, that everyone does have hospitals to go to, and that the care is based on what the patient needs, not on adding another bill. So no matter who the payer is, and in part we have a mixed system. We have Medicare and Medi-Cal in California. We have veteran services. We have healthy families, at least for a little while, for kids. But if it's government as the payer or through employer-sponsored or individual, the point is that someone has to pull together all of those providers and match them up with the patient to work. Therefore, health plans that are good at what they do fulfill that role, and they fulfill it whether you're an employer who has many employees or whether you're the government and you're looking to get the frail and elderly out of nursing homes.
Perfect. Well, thank you very much for joining me here in the Capitol. I appreciate it, and thank you very much.
This presentation of Vision for California with Senator Ed Hernandez featured special guest Patrick Johnston, the CEO of the California Association of Health Plans. We invite you to check back for upcoming segments. Thank you for watching. See you next time.